So I want to acknowledge with a lot of respect and joy, really, that we're hosting this session on the unceded and ancestral territories of the Coast Salish peoples. That includes the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, as well as the Métis charter community of the Lower Mainland region. And each of you, wherever you are in this province or in this country, are on a territory which you need to learn more about, be grateful for, and respect the land and the people on it. And with that, I'd like to introduce our speaker this morning, Dr. Sofia Ahmed. She's a professor at the Cummings School of Medicine at the University of Calgary. She's a clinician scientist and nephrologist with a focus on sex and gender differences in human, kidney, and cardiovascular physiology and clinical outcomes. She's the vice chair for the Department of Medicine and lead of the Alberta Strategy for Patient-Oriented Research Capacity Development. And she also leads the Women's Cardiovascular Health Research Initiative at the Libin, lots of cardiovascular institutes at the UBC, but anyways. She's also an advisory board member for the CIHR Gender and Health Institute and the incoming president-elect for the Organization of the Study of Sex Differences. And I've learned a lot from her over the years and have really valued her perspectives and the way that she helps us to understand better ourselves and the way that we both approach research as well as ask and answer questions. I would like to turn it over to her now and also let people know that she was the awardee of the 2020 ASN Distinguished Mentor Award, as well as the May Cohen Award for Women Mentors. And so really has a lot. And EDI, for those of you who don't know, stands for Equity, Diversity, and Inclusion. So Sofia, over to you, and thank you again.
Just trying to unmute myself, so just a minute. Thank you so much for that very kind introduction, Adira. I'm truly delighted to be here and I'm really honored to be invited to speak to you today about a topic that we all are hopefully, and I'm sure in this audience, are thinking about: equity, diversity, and inclusion in research. And at the end of this talk, the hope is that we'll all come out with more things that we need to know. So if you log off like right now, just remember that EDI saves lives. And if you remember nothing else from this talk today, like that's truly the take-home message that I would love for you to leave with. So, I would like to acknowledge that I am speaking to you from Calgary. And so this is the traditional and present day territories of the people of the Treaty 7 region in Southern Alberta. And the city of Calgary is also home to Métis Nation of Alberta Region 3. And so I'm very grateful to be here today. So I'm going to start off with telling you a little bit about me. I'm fortunate to know many people in the audience, but you may not know everything about me. So as you know, I'm a nephrologist. I'm a clinician scientist. I'm interested in cardiorenal outcomes, clinical and physiology. From a more personal perspective, my mother was born in Ottawa. She's white, she's Anglo-Saxon. My father immigrated from India as a graduate student. I'm cisgender. My pronouns are she and her, and cisgender means that my sex assigned at birth, what it says on my birth certificate, aligns with my gender identity, being a woman. I'm married in a straight relationship. My first language is English, so I speak it and write it with facility. To date, I do not live with a chronic illness or a disability. And my parents both have post-secondary education in STEM and careers in STEM. And I grew up in a household where we were comfortably above the median household income in Canada. And so you may be like, okay, why are you telling us this, Sofia? And I'll be honest, it is incredibly uncomfortable for me to tell you these things. But the reason I tell you these things is to acknowledge my unconscious bias and, my unearned privilege. And unearned privilege, what does that exactly mean? So unearned privilege does not mean that I have not worked incredibly hard to get where I am today. It does not mean that I am not working hard. It just means that these are all things that throughout my journey to get where I am today, I didn't need to think about any of these things because the world is is really built for many of the aspects that I just highlighted. And I didn't need to expend any energy thinking about, well, how will I navigate this? And the reason that's important is because of this, I may be blind and have systematic bias in what I think are important research questions, how I design my studies, who I include on my research team, who I recruit to be part of my studies, how I analyze my data, how I present my data, and who I think needs to know about my data. And so these are just important things that we all need to remember. So over the next, I will not go over time, let's say 30 to 40 minutes or so, we'll talk about why EDI is important to health, what impact it has in the research team, and how that impacts the science we do, and then some practical and evidence-based tips on how do we incorporate EDI into research. So, your first question, and I suspect by being in this audience, you all know this, but like, what exactly is EDI? So equity is not the same as equality. So equality on your left here is treating everybody the same and recognizing that there will be different outcomes. So here, everybody gets the same box, and the outcome is watching the game. Some people have a great view, some people have an okay view, and some people have no view. Equity is, the goal is that everybody has the same outcome. And so you give people the resources and supports they need to achieve that same outcome. So you can see this first person never needed the box. This person just needs one box. This person by 2 boxes, great. Everybody's watching the game. So what about diversity and inclusion? So Verna Myers is the VP inclusion for no less than Netflix. So this is not something that is limited to healthcare, health research, science in general. All aspects of society are recognizing this is something we need to do. So diversity, being invited to the party. Diversity is being included in the research project, being part of the team, being part of the study population. But inclusion is being asked to dance. Inclusion is asking the person, it's not just a checkbox. Okay, we've included a person with X characteristic. What do they think? Do they think this is an important research question? Are you giving them co-authorship? Are there resources that are being specifically designed to include different populations? That's what inclusion is. And I really, over the next, as I said, I'm going to aim to provide evidence-based research in EDI, and most of the research has focused on gender and race, but it's important, so that's what I'll talk about today, but you can insert any other aspect or characteristic, and probably the same research applies. So I just want to highlight that there's lots of other aspects to EDI. And I meant to mention at the beginning of my talk that I am aiming to use first person and inclusive language. If I do not, or you hear something that doesn't resonate in the right way, please either A, call me out publicly, or B, just send me an email afterwards, because I'd be very happy to chat with you about it. So the first thing to recognize is prejudice and racism are different things. So many of us, and I think all of us, hopefully would say, I am not a racist person, or, I work, I'm part with people, I'm part of my family, my friends, I might identify with a particular group, and I don't think differently about people depending on X characteristic. But that is different, that's describing prejudice. And that's different from racism. So racism, we all live, work, study in institutions and organizations that were designed a certain way that do have structural racism within them. And I'll tell you a little, and it's important to recognize that we all have a role to A, recognize it, and B, dismantle it. So this is an example of a since deleted tweet from JAMA, one of the most prominent journals in the world, where they did a podcast on racism, or they perceived the lack thereof of racism in medicine, because they didn't recognize the difference between prejudice and racism. So again, if no physician is racist, how can there be structural racism in healthcare? And the reaction to this tweet and podcast was swift, and because there is a lot of recognition that regardless of what you may, or I don't mean you, but like what we may think of ourselves, that does not mean racism doesn't exist. And so now there's actually that in the JAMA editor, that's an opening for a new JAMA editor. So, here are some examples. This is New England Journal. This came out in 2020, highlighting how prevalent race factors, and I say race, and really it's people who are, the factor is, are you African American or Black or not? And just highlighting, and you probably can't read this, and maybe that's quite telling, but just highlighting the number of validated equations that incorporate a race factor to determine treatment. Are you admitted to hospital? Do you get a particular treatment? So just the fact that you can't read this, because I can't even read it looking at my screen, is, I think, quite telling. Everybody in this room knows that nephrology is certainly not a specialty that doesn't have its own share of embedded racism, and so pleased to see, as you know, this is American, but NKF and ASN have recommended removal of the race factor from calculation of EGFR, and I understand that this is also happening in Canada, and it has already been employed by multiple health regions. So we'll talk a little bit about COVID because it's the most pressing thing right now. So this, in Canada, we do not collect race-based data. The US does. And so this is from Maclean's, again, shortly after the pandemic started, just saying that, and we all have seen this, that COVID does not affect everyone equally, and it disproportionately affects people. There's multiple terms that are used, but people who are not white. And there are many factors that go into that, but this is not something that is captured in our data sets in Canada. So let's talk about US data where they do capture this. So this is from November from the CDC, that just highlighting that there were over 750,000 people who on their death certificate, it said COVID was the cause of death. But then this is out of Boston University that looks at race-based data. And so it's important to recognize, I do not know how they capture this race-based data. Is it self-identified? Is it someone looks at someone else and says, I think you are X? And so that's obviously problematic. But this is what they have. So basically, you can read this as well as I, nationwide, Black people have died at almost 1.5 times the rate of white people. And so, why is that? And that is a conversation that is beyond the scope of this lecture. And there are multiple factors, but one I'd like to focus on is the pulse oximeter, which we use all the time in medicine. And so there's actually a study, again, that came out once the pandemic started in 2020, but it's actually using data from before the pandemic out of University of Michigan. Again, it's all American data. And this is not the easiest graph to take a look at, but basically on the y-axis here is arterial oxygen saturation. So what was the O2? These are pairs in the same person. So what was the O2 sat measured by an arterial line, and what was the O2 sat measured by pulse oximetry? Some of these patients are ICU patients, some of them are not, but it's over 10,000 pairs of O2 sats. And basically they stratified people whether they were white or Black. Again, they did not put in the methods. I do not know how they captured this data. And all you need to recognize is that, so these are white patients. And so the true O2 sat was, in the mid, but like 87, 88. And oh, look at that, the pulse oximeter measured that as well. But in someone who was Black, the arterial O2 sat is here about 86%, but it actually measures being closer to 89 or 90%. And when you think about COVID triage protocols, having severe COVID is having an O2 sat less than 92%. So this has implications for who gets certain treatments, who gets admitted to hospital, who goes to the ICU, who gets intubated. So just an example of this is structural racism. It's, again, this is not something that's limited to medicine, but it is getting interest from people outside of attention, not interest. And the pulse oximeter doesn't work particularly well on people with female, they say women as well. So, I suspect the people who designed the original pulse oximeter, which is a great medical invention, by the way, had no intention of having it be a discriminatory device or not working as well in some people other than others. And I suspect that their research team was not particularly diverse, so didn't recognize that it would be important to test this device on people with varying skin shades, people with different biology, meaning by sex. So again, just highlighting, no individual is racist, or you know what I mean, but like there are systemic processes in place that may be racist. So going back to COVID, we talked about there are racial differences in who dies because of COVID. I mean, this is pretty significant. So one would think that if you are part of or a person is part of a group that is at higher risk of dying from this, from the virus, there would be greater uptake in that population of the vaccine. And that is, I'll just focus again on African-American population. And this is not true. So on the left here, on the right, is the percentage of the American population who, stratified by race. On the left side here is the percentage of the American population who has been vaccinated, stratified by race. And so you can see, at least in this study, again, as I said, out of Boston University, between 12 and 13% of the US population African-American, but at the time of this study, only 10% had been vaccinated. So, why is that? And again, it's important to go to data. So this is a study that came up before vaccines were available, but after the pandemic had started, or the data was collected during that time. Isn't that funny how that's how we classify our research now, like pre-pandemic, pre-vaccine. Anyway, so this was a nationally US representative survey on asking people, once the vaccine is available, do you plan on getting it? And basically they found that, so here's a line, I'm pretty neutral. Everything on this side, I don't want to get it. Everything on this side, I will plan to get it. And you can see that those people who, female and Black, those were the characteristics that were most predictive of saying there's no way I'm getting this vaccine when it's available. Interestingly, being a Trump voter was the next one. And then on the other side, those who said, yes, I am going to get the study, are those who had trust in experts. Vaccines are effective, they're important, and they are safe. So, I mean, we know what we need to work on. There actually has been a study that came out, basically asking the same thing, but more, did you get the vaccine after the vaccine was available? And it's pretty much the same thing. Actually, I shouldn't say that. Women are more likely to get the vaccine, but the African-American population still lags behind other racial populations in the US in terms of getting the vaccine. So it's important. So it's easy to pontificate, why is this? And this is where it's important that whatever aspect of research we're looking at, we understand the history. Because without that, we'll never reach, I'll use the word reconciliation or build trust in science. So Henrietta Lacks, many in the audience may know her story. So she was from a very poor family. She was an African-American tobacco farmer, and by age 31 was the mother of 5. She developed vaginal bleeding and went to Johns Hopkins Hospital in Baltimore, which at the time was the only hospital who would take uninsured African Americans with health problems. Excuse me. She was treated by a gynecologist, Dr. Howard Jones, who diagnosed her with cervical cancer after biopsy. And unbeknownst to Ms. Lacks, a sample of her biopsy was sent to researcher, Dr. George Gay, who was trying to develop an immortal line of cells for research. And had no success. So he was collecting biopsies from everybody basically at Johns Hopkins. So he'd had zero success or very little success until he received the sample, Ms. Lax's sample, and her cells doubled every 20 to 24 hours. He'd never seen anything like it, and started giving her cells away to all of his colleagues, saying, oh, this is a great sample. You need to have it. Ms. Lax died shortly after her treatment started at age 31, completely unaware that her biopsy had been given to Dr. Gay, let alone that had been passed on and or any of this. So this was not something that she or her family knew. So you may not have heard of Henrietta Lacks, but you have probably heard of HeLa cells, and that's how the name HeLa came from, the first two letters from her first and last name. And HeLa cells are the most famous cells in biomedical research and probably in science. They have been used, like, think of anything, and they have been used. They have gone to space. They have been used for development of COVID vaccines. They've been developed for like all vaccines, essentially. And at least one study has estimated that by HeLa cells being available, they have expanded the global life, like on an average scale, by 17 years. I don't know how they calculated that, but so just, I cannot underemphasize the impact HeLa cells have had on the scientific world and our collective health. However, as I said, Henrietta Lacks never gave consent, never knew, her family didn't know. And it's been, she would have been 100 2 years ago. And here he says nobody, like, consent is still not required for all samples to be given for research as well. And so this story, I highly recommend everybody in the audience to look at. You get this at Chapters. It's a great book. And it basically just, highlights the history of Henrietta Lacks and HeLa cells. And it's actually been picked up and made into a movie by Oprah Winfrey, which I have not actually seen, but the book is really good. And it's an important thing, I think, that every scientist should know. So another study that we should all know about is the Tuskegee study. So in 1932, the US Public Health Service said, we would like to do a study looking at what is the natural history of untreated syphilis. And they specifically went to rural Alabama and specifically recruited very poor, poorly educated African-American men. And you can see they got 400 men who tested positive for syphilis and 200 people who tested negative. This is one of the study investigators, and these are some of the participants. And you can see this is how they took samples. There was no consent in the study. There was misinformation as to why the study was happening. They did lumbar punctures every 6 months, and they told people, you're getting a special treatment, whereas there was actually no treatment. It was just a way for the investigators to get samples. 15 years after the study started, penicillin became standard of care for syphilis. However, the investigators decided that they would not let their participants know, and they would actively prevent anybody from receiving treatment. And because they wanted to keep following what is the natural history of syphilis. And in fact, this study continued until 1972, so 40 years after the study started, not because the investigators finally said, like, this is unethical, but because the New York Times investigative journalist broke the story. But it took an additional 25 years for the participants in this, I use study with quotation marks, for an official presidential apology. So here's Bill Clinton, and here is one of the 8 remaining sole survivors of the original 600 men who were recruited. Everyone else had died. Many people's partners had all become infected. So, families crumbled, children became infected through vertical transmission. So, like, there was a lot of harm. We'll just leave it at that. We are pretty good in Canada at looking at the US and saying, that would never happen here. This is not, that's what happens in other countries. And in fact, we have a very shameful history of medical experimentation in Canada as well. So this is in residential schools. This is a very hard photo to look at. this is a child in the residential school system, and this is a government the Canadian government federally funded, I don't even know, healthcare worker, scientist taking blood. They did experiments on these hungry children, and half of them would get supplements, meaning like vitamins, and the other half were the, in quotations, controls. Not clear what the outcomes were, not clear, there's no documentation what they were actually looking for. But just to highlight, like, we have a lot of work to do more, like, and every day I learn something new, to build trust in our science and healthcare system here in Canada. So, okay, we've talked about why EDI is important to health. So let's talk about the impact of having equity, diversity, and inclusion in our research team. How does that change the science and the healthcare that we deliver? So this is Calgary-based data, and it just to highlight, we in Calgary have had very good uptake of COVID vaccines because of partnerships, or not just partnerships, actually leadership within the Indigenous community. So here's just an article in the Calgary Herald. Here's another successful clinic that was done, and just recognizing that it's important that we can have fantastic health outcomes if we just listen to the community that we are collectively would like to engage with our research, our healthcare, etc. And again, back to US data. So this is in the Wall Street Journal. And so just reading, among US counties of 1,000 people or more, 12 of the 15 counties with the highest vaccination rates in the country were counties that had using the terminology of the US government, Indian reservations or Alaska Native communities where the Indian Health Service or tribal clinics are the primary source of healthcare. So again, highlighting the importance of community engagement. This is out of Toronto. I do not know Dr. Upton Allen. He is a professor of infectious disease and basically led a study looking at COVID in Black Canadian communities. And when members of these communities were interviewed, what prompted you to participate in this work, basically said that Black representation in COVID-19 research was vital, that the community would not have participated except that they saw someone who looked like them, who was leading this work. And so the trust was there. Okay. Many people may or may not have heard of Dr. Kizzmekia Corbett. So she is currently an assistant professor at Harvard University. At the time, she is one of the co-inventors of the Moderna vaccine for COVID. At the time, she was a senior research fellow at the NIH. And I don't know too many scientists who, just regular scientists who have this kind of following on Twitter. She's been featured in People magazine, as you can see. And this is just an example. I do not know this person who tweeted this out, but just again to highlight, round one done, finally. I took my first dosage of the Moderna vaccine, which was led by @Kizzy PhD. Dr. Kizzy is a Black woman who is literally trying to save lives with her research. Two things I trust are Black women and science. Dr. Kizzy is the 2-for-1. And so, okay, that's a random person on the internet. We always trust those people. But, no less than Dr. Anthony Fauci has said the same thing. So the first thing you might want to say to my African-American brothers and sisters is that the vaccine that you're going to be taking was developed by an African-American woman, Fauci said. And that is just a fact. And so, great interview. Thank you, Dr. Fauci, just highlighting. And the only thing I would change, though, in the reporting here, if this will go forward, I guess there's a delay, is I would include the doctor. So it is, again, studies have shown that there is, so this is actually called untitling. And this is a very real concept, and that specifically women and people who are not white are often untitled. So here's another example. Dr. Anthony Fauci said Kizzmekia Corbett, why is there not a doctor here as well? So just something that Again, I'm sure the journalists did not, all three journalists did not do this on purpose, but we all have unconscious bias. So, okay, let's talk about some research that highlights, you could argue these are anecdotes, but like, there's actually research that shows the impact of diversity in the research team. So these are two economists, actually a professor and a postdoc, who looked at the link between a research team's ethnic mix and how often their papers were cited. So what did they do? So they looked at all papers that were published in the Web of Science between, so what is this, over a 23-year period. And it wasn't specifically health research, it was 11 different scientific disciplines. They looked at data that was specifically published out of the US, and the reason for that is to have more equitable access to different resources, which differ across countries. And they ultimately came up with 2.57 million papers. Then what they did is they looked at the last names of the authors on the papers. And they classified using a validated algorithm. So they classified people into 9 different ethnic categories. And again, it's a validated, you could argue, obviously it's an imperfect way of doing things, but anyway, it's the way they did it. So, like Russian last names together, Chinese last names together, Anglo-Saxon last names together. And what they found is, first thing, in science, there is tremendous homophily. So I've had people say, well, what is homophily? And so homophily in general is that, people of similar characteristics tend to hang around together. And we see that, right? In our neighborhoods we live in, the people we hang out with, the people we, have romantic relationships with. But it turns out we do that in science as well. So we tend to do science with people who are similar to us, at least ethnically, according to this project. And it turns out that those people who have more homophily in their authors publish in lower impact journals and are cited less. And conversely, those that have more heterophily have the opposite, more impactful papers or in impact journals and more citations. Now, I'm not like, this is an arguable outcome, right? Like, this is not necessarily the most important science, but the point is that more people are reading this work, and hopefully it's getting translated into policy. And so there is actually more than it's the right thing to do, but you actually do better science if we have different types of people in the research team. So this is a similar type project, but looking at gender of the authors. So basically, they wanted to see is, depending on the gender of the authors, does it result in differences in sex stratified reporting? So basically, they looked at mesh headings and, based on the gender of the authors, what was the likelihood that there would be sex-based terms included in the mesh headings in PubMed? And so they looked specifically at health research, over 11 million papers between 1980 and 2016. And if I can direct your attention just to these top 3 up here. So they just looked at the first and the last author of the paper. And again, using a validated algorithm, determine what the gender was. And they used a binary woman and man. I mean, it says female, male, but really what they mean is woman and man. So my name's Sophia, they would have assumed I was a woman. If someone's name was David, they would have assumed they were a man. And their referent group here was a man first author, man last author, and paper published out of North America. And you can see that basically, so man first author, female last author, the reverse, or female, there was all of those combinations were associated with a higher likelihood of having sex-based reporting of the results of their work. And you might be like, well, like, why does that matter? And, I would come back and say, well, evidence-based medicine, which is what we all strive to use when we treat people, is historically based on a male model. So, in cell-based data, 80% of cells are either male or they don't even report the sex. Animal-based data, 3/4 of animals are male. Clinical trials, 2/3 of participants are men. But when we get to clinical care, it flips. And women are more likely or are bigger healthcare consumers than are men. And that's partly for, and again, this is using cisgender language, sex-based reasons, because, pregnancy, reproduction, contraception, menopause, there's more opportunity to see the doctor. Women live longer than do men. By age 80, there's 5 women for every 2 men in the world, 3 men in the world. By age 85, it's 5 to 2. And women live with more complex conditions, partly because they live longer. And women are also more likely to access medical care for the same health concern compared to men. And that's been shown across a variety of symptomatology. So I am exaggerating, but it's almost like, and I am exaggerating, but it's almost like a clinical experiment every time we prescribe a new treatment to a woman, because she has not been represented along this pipeline, getting that treatment to market. And this is really important because this is US data, but out of over a 4-year period, 8 out of 10 medications that were withdrawn from market because of serious adverse events like organ failure or death. 8 out of 10 of these drugs pose more of a threat to women. And again, going back to, they haven't been represented in that pipeline to get these drugs to market or treatments. So lastly, how do we incorporate EDI into research? And I really want to mention, if anyone's feeling totally overwhelmed, you're totally normal. I get incredibly overwhelmed and I do this work. So this is hard and it's okay. And we're all working together to try and make things better, and we can learn from each other. So the first thing is, it's one thing to say that, oh, we're doing a great job, or we're not doing a great job. If we don't measure, we do not know. And so metrics are the most important thing. So CIHR is starting to recognize this. So as anybody who's recently submitted a grant, that you have to, you don't have to, you can say, I prefer not to answer for any of these questions, but they're trying to get a sense of who's applying, what are the success rates, what are the success rates? And it's a start. So after George Floyd was murdered, a number of prominent, all of these journals, who are obviously the highest impact in their respective fields, put out diversity statements and said, there's systemic racism in society and in science and healthcare. And so we need to listen, learn, and change. And so, everybody made a commitment, which is fantastic. But again, New York Times investigative journalism, Catherine Wu went and spoke to the editors of each of those prominent journals that I just showed you and said, that's great, you have a diversity statement, so what are you doing? And they all said, we actually don't have any processes in place. So we're committed, but if you're not, the words are important, but they're not enough. So we all have unconscious bias, we all do, whether we want to admit it or not. It's just part of being human. Our life experiences form how we think. And so again, I told you I'd show you science or evidence to show. So this is an RCT looking at, again, US-based institution faculty in biology, chemistry, and physics. So 127 people. And basically, everybody got sent an application from a recently graduated undergraduate student who was looking to be a lab manager. And all they did was change the name of the person. So, a female name, or a woman name, I should say, and a man name, masculine and feminine. And they asked people, so how competent do you think this person, how hireable, and how worthy do you think this person is of mentoring? How much benefit would they get? And you can see that for everything, that the male student scored higher in all these things. And not only in these things, but actually when they said, what salary would you offer? The male student was offered almost $5,000 more. So just highlighting that we all have unconscious bias. And then when they looked at who these profs were, they looked at, okay, did it matter what the rank was of the person? Were they associate, assistant, full professor? Didn't matter. Was the person a woman? Was the person a man? It didn't matter. So again, just highlighting that we can't say, oh, I belong to X group, or I've experienced X. Like, we all have unconscious bias that we have to acknowledge and actively work to not let it influence our decisions. So this is out of France from their research, similar to CIHR, their equivalent. And basically they work a little differently. As you can see, they have all these different committees. And based on what I read in the paper, people apply to each of these committees and say, I would like to be promoted to rank of something. So it's independent of your institution. It's a countrywide thing. And so all of these committees, with the exception of cultures and societies, recognized we have underrepresentation of female elite researchers. So I guess you're promoted to being an elite researcher, which probably comes with tons of money and resources. So they said, okay, we need to do something about this. So they came up with this study where in year one, they told people, we are going to do this study to see if we can change how many women are promoted or study it. And everybody said, okay, we'll do it. And so then they had their selection to sit, and then they did nothing else. Everybody sat in their individual committees. They looked at the applications and then decided who was an elite researcher. And then after they made those decisions, that's when they did the study. So they did an implicit association test specifically based on gender. And they also did an explicit, like a questionnaire, like what are some things that you think might be obstacles to women advancing in science? And so anyway, and as you can see, it's about 2/3 men, 1/3 women, and 6 people who declined to put down their gender identity. So then a year later, similar committees, they went back to their usual thing, what they always did. And then they just analyzed it. And they found that, I don't know why that just happened. The year that they did this study after the fact, so just note that there was a greater proportion of women promoted. So let's say 30% of the applications were women. It was closer to 30% of women who were given the title of elite researcher. But the year they didn't do that, it went back to the usual thing. So just highlighting that you don't even need to do anything beforehand, but just these people knowing that the study was coming influenced how they decided. How about hiring? So this is a study out of University of Michigan. They had 23, I should go back to this, 23 different search and selection committees, half of which got a special intervention, half of which didn't. They were all STEM-based committees. And so group one, the intervention group, got a special presentation similar to today, talking about unconscious bias and how to overcome that in terms of to prevent it from influencing your decisions with the facts that you have in front of you. They also got a guidebook on how to recruit or attract a diversity of candidates. And interestingly, the candidates who came were, in addition to interviewing, also met with HR totally separately, had nothing to do with the interview committee, so that they could talk about, these are the things that I need to be successful in academia. And can you tell me about what the university has? And the other group got the standard, which is basically, this is how you have to be in compliant with university processes. These are the procedures you have to follow, and these are the questions you can't answer or you can't ask. So, kind of pretty basic stuff. So, and perhaps not surprisingly, those that had the intervention, there were more women who were shortlisted, so were even felt to have met the bar, were phone interviewed. More women were invited to be a finalist for the position. More offers were given to women, and equally importantly, more women accepted these offers. So it's important that we all recognize it's not all about like, okay, let's make sure we have a diversity of candidates. We actually have to impress the people and make them want to come and be here and, convince them that this is a place that they can succeed. And so there's lots of, I really highly, nature is great in terms of having these great articles on with almost checklists and guidebooks on how to do this. So here's another one. So recruit and retain a diverse workforce. I want to spend a little bit of time talking about, and I'm cognizant of the time, candidate assessment. So this is more specific to students. So I have a lab, many people in here have a lab as well, and hire students or research in the research program. So traditionally, we look at what's their GPA, how many publications they have, how many first author they have, also how many conferences they've been to, are they oral, are they poster presentations, and how many awards do they have? So, if they gotten in Alberta, would it be an Alberta Innovates Health Solutions Award in the past? And you think, okay, this is a good person. I don't mean a good person, but this would be a good, I'll use the word fit, which we shouldn't do for the lab. When this article that I just showed you actually says we need to flip that. And, when we look at these things, we have to consider access to resources and opportunities. So, for example, I just talked about, I'm not trying to throw Alberta under the bus, but like Alberta Innovates Health Solutions, their summer studentship for an undergrad student to work in a lab for 4 months is $6,000. Minimum wage in Alberta is $15 an hour. So like my daughter works at Dairy Queen. She makes way more money working at a fast food facility than if she did working in a lab. And if you're somebody who is trying to pay for your undergrad or contribute to your family's finances, like there's no way that you're going to take, you're going to even think of a summer studentship because it just doesn't work. So just to highlight, like these are lived experience is really important. And we should be thinking, does our program have what it takes for the person in front of me to be successful? So if you have someone who, has worked part-time throughout their entire undergrad and has done reasonably well, that's a pretty organized person. And maybe we should take that into account. And it's predictive of future success. So I just want to highlight, like, we can't just take people into our labs, into our research teams, and expect like, okay, check. This goes back to the diversity is inviting people to the party, but inclusion is inviting them to dance. We need to talk about mentoring and better yet, championing people. And there are many great mentors out there, and it's a lot of work, and it's very rewarding work, but it's work. And we might have like one this is how I mentor people. I always invite them to do, I'm going to use extreme examples. We always meet as a lab on Friday nights at the pub, and it's great. We bond, we talk about stuff. Well, that's going to exclude all of these other people who, maybe for religious reasons don't feel comfortable at a pub. Maybe they have family or other obligations, or maybe they have a part-time job and they really can't give up Friday nights. So just recognize that what works for one group, you need to tailor your mentorship and onboarding depending on the person in front of you if you want them to succeed. And oftentimes, unfortunately, and I know everybody in this audience knows this, we see that, we've recruited someone who is historically underrepresented or excluded in research or in healthcare. So let's ask someone of a similar background to be their mentor. And the minority tax is very real. So we all have to report on research, teaching, and service, on our annual, that's how we're evaluated, we're promoted, we're given resources. And if you're someone from a historically excluded group and you're being asked, you're rated on research, teaching, and service, but you're being asked to mentor someone who is going to need a lot of help as they're navigating this new environment. This person themselves is probably, might be feeling quite isolated, might be feeling that this is a racist environment, etc. So, this isn't fair to ask only one type of person, and they're the same people who get asked over and over, will you do this? And I want to say, and there are no resources that are often put towards these things. And so that's important. So I'll just finish off with conferences, which are now starting to be in person again. So going back to our trainees, and so this is US terminology, URM, underrepresented minority. And just basically looking at, as we know, we would love for our students to all have oral presentations. We love when they have poster presentations too, and oral presentations just get that extra, that's fantastic. And so just looking at which trainees are invited to give oral presentations. So it's usually not a URM person, and it's URM women who are the least likely to be invited to give a talk. For when trainees submit their abstracts for presentation, again, it's the same thing in assigned talks. And what's really interesting though is part of that is that URM women are least likely to ask for talks. They're more likely, they're overrepresented in saying, I would like to only be considered for poster. So that just highlights that it's on both ends, right? Like as mentors for our early career colleagues, we really need, there's some groups that, need the support and the championing from people who are in more senior positions to say, put yourself out there. Yes, you want that talk. And also on the abstract scoring side, the conference organizers to recognize, okay, do I have some potential bias that's influencing my ranking of these things? In terms of location. So, we think I would like to have my conference in a fantastic, nice, warm place. I was just talking to Brenda about this at the beginning of the talk. And that's great to consider. We want locations that are lovely to go visit, but we also want locations that are safe, right? Like there are places in the world that being gay is a crime. There are places in the world that being trans is a crime. And so why would, if you are part of those groups, you would not go to that conference? And we know that conferences are ways to network. We talked about presentations, show our research. And so it's something that is not taken into account when we plan locations. And so the American Physical Society has actually taken this, has developed a framework for where they are going to have their conferences. And I'm really pleased to say that the American Society of Nephrology, I brought this to them, and they are considering this as well. So they have the APS has recognized in their words that there are very few Black and brown physicists. And this is, when I think about it, if you're going to have the APS's society conference is in Minneapolis. This is where George Floyd died. If you are part of a particular group, you may not feel comfortable going to a place that has a police record that is not friendly to, and that's a euphemism, to particular groups. So just something to recognize. 18%, almost 20% of the working age population lives with a disability, but fewer go to higher education, and even fewer are represented in faculty. And when you think about the last time you gave a talk, and it was different, I guess here I am at Zoom, but like walking up to the podium, there's usually steps. So like if you're someone who, I'm using mobility, there's lots of disability and chronic conditions that may not be thought about when planning a conference. Okay, there we go. So again, if you're feeling totally overwhelmed, it's okay, I'm almost done. So you think, well, okay, I want to be more EDI in my work. How do I do it? There are actually checklists. So, here is an example, and you can actually use this to evaluate your research, like starting from the very beginning. And this is, I really like the SHRC one. This is what they use for the New Frontiers in Research Fund competition. So they have best practices. This is something, if you want to see if your work is gender sensitive, and gender, it's not just gender identity, it's also socioeconomic position, domestic responsibilities, etc. And so I end, if this will advance. There we go. So in summary, again, if you remember nothing else, EDI saves lives. We need to, if we have more diverse research groups, we increase the scientific impact and generalizability. We can't just have diversity statements. We have to have metrics, and you have to put resources behind it. Actually, that is a metric of EDI. What resources is the institution putting behind it? If it's just a checkbox to say like, oh, I needed to do that for my grant, it doesn't count. You get what you screen for. Mentorship, we know this is key. And then when we think about our conferences and our scientific symposia, these are things to think about, and that's it. So I would normally leave this up for questions, but because it's Zoom, I'm going to put it back on gallery. Thank you.
Thanks, Sophia. Maybe what we'll do is we'll stop sharing. Right?
I forgot to include that. I skipped over. Sorry. If you want to look at nature, it has a lot of great tips for when EDI tips. Anyway, I'll stop sharing.
Great. So I'm going to open it up to the audience. You know that you can put a question in the Q&A, or you can raise your hand and Brenda will unmute you. But so one of the things that's interesting is lately, much influenced by a lot of what you've taught us, is that when I actually review a paper and I see that there are men and women, but nobody's discussed differential impact of the treatment, I've asked them to potentially explain it or call it out, or did they actually look at it? And I think that that's, you know, as you said, like there's a lot of things that people underestimate in terms of that kind of information when they're reporting a paper. But I also want to go back to the thing you said about various things that have been created that may have gender or race bias. And I was once told, and I'm not sure if this is still the case, that most of the instruments that were created for cardiac cath and cardiac surgery were created for use by men for men, and not for use by women but for women, and that some of the consequences of cardiac outcomes or interventions for women may be attributable in part to the lack of appropriate tools. And I don't know if you've seen that or read that, but I found that quite interesting and had sort of gave me a bit of an aha moment. You're muted.
You raise a really good point. And I couldn't cite any studies specifically on the card. I believe that it's not specific to it. So like iPhones originally, like if anybody tries to take a selfie or like, it's too big for my hand. And that's because iPhones were created based on a bigger, like a male hand. I've recently found out that, like, I don't know what the standard city size block. So, you know, you walk a lot in Vancouver, which is fantastic, and is based on the stride of a 6 foot man, a 6 foot tall man. So cities, and you think about like, so think of New York, right? Like they have subway systems and they have lots of stairs. They're not designed for people who have, and this is not a sex-based thing, but like who have children and strollers or who are mobility challenged. When you go to the grocery store, the standard shelving size is, again, also based on the 6 foot man. So like I really struggled to get the top thing. So I'm really cold in the summer at work. I always bring a sweater because the air conditioning is so cold. That's based on the average metabolic rate of a 40-year-old cisgender man, which at the time when like heating systems were put in, that probably was the average worker in the office. So that's fair. And that's changed now. So your point, and not, I'm sure in medicine, it's the same thing.
Yeah, no, and I think the more you think about it, the more, you know, it makes us, you know, wonder and worry. And when you see differential impacts of drugs or procedures or people doing better or not, pointed out, by design. By design. Yeah, I'm encouraging. We're just actually at the bottom of the hour. I had thought that we had a bit more time, but really, I think on behalf of all of us, thank you for a really thoughtful, but also inspiring talk, because I think that certainly in this province, we talk a lot about EDI and we are trying, and we're not perfect at it, but whether it's in our clinical practice or in our research or in our education, I think we need to be very mindful of the value of the diversity of perspectives when you go to put a committee together, to be really careful and thoughtful about it, and to not be afraid of different opinions or thoughts, because that, as you said, brings a different kind of lens, for sure.
Absolutely. Well, thank you so much for having me. I really appreciate it.
Yeah, thank you. Thanks for making the time.
Okay. All the best.
Bye, everybody.